Hello, everybody. Welcome to the Grand Rounds, those of you here in Baltimore and those of you at home online, both live, and we'll be having also a large number of archive folk watching it later. So we're glad to have all of you here today. This session is sponsored jointly by the DHSI, Division of Health Science Informatics, here at the Johns Hopkins Medical Campus, and also the new Center for Population Health IT, CPHIT, or CFIT is where we like to call it. Again, a new center that I at the Public Health School am leading. And I'm Jonathan Weiner. I'm a faculty member at the Bloomberg School of Public Health and also on faculty at the DHSI and the founding director of CFIT. We're really lucky today to have a great presenter, Dr. Michael Furukawa. Michael is the director of the Office of Economic Analysis, Evaluation, and Modeling. He's the number guy, the quant guy, the return on investment guy at the Office of the Coordinator for Health IT, ONC. And as you know, the entity that, in my opinion, is behind one of the biggest changes in our healthcare system is, in fact, the ONC in partnership with CMS and the meaningful use money. You know that meaningful use has become a buzzword, a code word for so much more. It's the largest pay-for-performance program probably in this country's history, and rivaling only the British pay-for-performance program. But unlike other programs, it's about one thing on the surface. That is getting an EHR, EMR on doctors' desks and in hospitals like this one. And those of you here at Johns Hopkins know we're right in the midst of a huge rollout here of the Epic system. But one of the people behind it is Michael, and certainly the ONC and CMS and meaningful use. So Mike, who is an economist, and I'm pleased that we have 2 or 3 economists in the room, Mike, a lot of informaticists and clinical people. But Mike is an economist as well as an engineer. He has, I believe, a master's and a bachelor's from Georgia Tech and a PhD in economics from Penn. And so that's a unique combination. And he is one of the best known economists, if not the best known, focusing on this whole issue of does meaningful use and does health IT have an impact? So his topic today will be, as you see, meaningful use and electronic health records, progress in high tech. Now, we are streaming live. Those of you that are listening, let me just get the hashtag. Those of you that are listening live, that is at 12:15 Eastern Time today, can communicate via Twitter at hashtag JHInformaticsGR, one word. So again, hashtag JHInformaticsGR, and we'll try to monitor that to answer any questions. Those of you live here in the room, we're going to leave the last 10 minutes, 15 minutes for an open discussion. Please, we have a mic, and I hope we need the mic so people at home can listen. So please, for sure, save up your questions. And those of you watching this via archive, you can reach us. Either Harold Lehman or myself, Jonathan Weiner, can try to broker any questions for Mike, or you can finally find Mike. So again, join me in welcoming Dr. Michael Furukawa. And Mike, thanks again so much.
Thank you, Dr. Weiner, for that generous introduction, and thank you, Dr. Lehman, for hosting me today. So today I want to present some work at the Office of the National Coordinator on Meaningful Use. Many of you in the room and listening online may be familiar with meaningful use. I want to kind of walk you through the policy impetus, some background on the program, spend the middle part of my presentation talking about adoption of electronic health records, where we are in terms of physician adoption in hospitals, and also where we are with meaningful use. And then finally, walk you through some of the program evaluation work that I direct at ONC around what are we learning from HITECH and what are the remaining challenges. And so I'll end with some policy implications on some of the remaining challenges. So HITECH was really started in 2004 by President Bush, who issued an executive order to calling for all Americans to have an electronic health record by 2014. ONC was created. It was a small agency doing mostly policy work, but really in 2009, when President Obama saw the opportunity to to use the stimulus and have legislation to allocate money directly to health IT. So roughly $20 billion, actually a little bit more, $2 billion to ONC for programs and policy support, and then $22.5 billion for financial incentives for both eligible physicians and hospitals to adopt and meaningfully use EHRs. But HITECH wasn't seen as a technology initiative alone. That really IT is a tool, and it's a necessary tool to transform care. And so really the motivation behind HITECH was the three-part aim, which Don Berwick laid out in a Health Affairs article: better health care, better population health at a reduced cost. And so HITECH is this piece moving from paper records to an automated, connected record, and ultimately to widespread use of those records to transform healthcare delivery. So meaningful use is seen as a building block, not as a means to an end itself, but as a tool primarily to automate paper. So in stage one, there are three stages. Stage one is really about getting adoption of electronic records into practice. So stage one criteria focus primarily on structured data, things like CPOE or electronic prescribing, some clinical decision support, but also the regulatory framework, so privacy and security protections. A lot of the early effort in stage one and ongoing is to make sure that we have the protections in place to securely share records. So stage two has recently been launched. The regulations were launched earlier this year. And it builds on stage one by emphasizing interoperability and exchange. So a lot of stage two deals with how can we improve care coordination and how can we engage patients in their decision making by providing access to the record directly to patients. And so moving on to stage three, which is currently in discussions, we're planning for stage three to really take health IT and meaningful use and integrate it into health reform more broadly. So we see health IT and meaningful use as infrastructure to support patient-centered medical homes. So expanding on the use of data for population health management and patient self-management, as well as accountable care organizations. One of the things we're really proud of is integrating meaningful use into the ACO requirements for many of the certification programs. Meaningful use is also part of HHS's national quality strategy. So ultimately, meaningful use and EHRs are seen as a building block to get better health care, and ultimately lower costs. So again, three stages. We're not yet started stage two. The rules have been released. Stage two will go into effect around 2014 when providers will have to attest to meeting the requirements of stage two, and then stage three will follow. So HITECH. HITECH was legislation in 2009, a lot of directives to create programs and policies specifically to support adoption as well as exchange, with the central concept being meaningful use of certified EHR technology. So there are a number of requirements for meaningful use. There has to be certain functionality, which I'll get into in a minute, as well as the exchange and interoperability of the structured data that goes into EHRs. So this is the framework that was developed by David Blumenthal and others at the initiation of HITECH. And on the left are the main programs that were created by HITECH: regional extension centers, workforce training programs. In the middle is the financial incentive programs for both Medicare and Medicaid. And then to the bottom left are the programs to support exchange, including grants to entities in states to support health information exchange. Standards and certification framework. There was a new program to certify EHR technology to make sure it could meet the functional requirements to achieve meaningful use, and also privacy and security support that I mentioned earlier. So I'm going to take a bit of time to talk about each of the HITECH programs, just again to lay the context and to position some of the evaluation findings. So probably the most prominent HITECH program is the Regional Extension Center program. The REC program was modeled after the Agricultural Extension Cooperative program that was launched in the U.S. Around the 1950s, I believe, or 60s, to provide technical assistance to small businesses to improve agriculture in the U.S. And so the same idea was applied to health IT, was for the federal government to provide technical assistance to small practices of less than 10, and also practices in underserved areas. So we call these priority primary care providers primarily. And around $700 million was allocated to the REC program across the United States. There are 62 regional centers, very different in genesis and approach. Many were part of existing community-based organizations like QIOs, Quality Improvement Organizations, or they had been part of other state exchange organizations or community partnerships that had already existed. And so many of the RECs are the local extension of ONC in supporting adoption of electronic health records and ultimately to enable providers in that community to achieve meaningful use. The rapid adoption of electronic health records we recognize would require skilled support, skilled workers to implement and support EHRs and to train providers in health information exchange, as well as to develop new systems and innovative applications particularly on the patient side. And so there were 4 separate workforce programs that were built into HITECH. The university-based training program on the left is an award to 9 different universities. We're pleased that Johns Hopkins is one of those grantees, and congratulations to the students that are going through that program. Besides the university-based training, there was a large community college training program. So 81 community colleges around the country were given grants to offer both in-person and online training in various roles. So besides the training of the worker themselves, there was a curriculum developed to try to harmonize the knowledge base around health informatics, EHR implementation, and so forth. So there were a number of grantees. I believe there were 5 grantees that were awarded for the curriculum development centers. Johns Hopkins was one of those awardees, and they developed a standardized curriculum that I believe is available in the public space for other educators and vendors and so forth to come up to speed with some of the requirements of meaningful use in EHRs. And finally, there's a competency exam program to try to ensure that the level of capability was met a certain threshold, and so there's a competency exam, a health IT professional certification that is an optional element for workers. And so in the training, there are various roles ranging from implementation to project management, software development, et cetera. And so this was seen as a key area to support the whole process of getting the healthcare delivery system to meaningful use. The largest single program in HITECH in terms of dollars was the State Health Information Exchange program. Around $700 million was allocated to state-designated entities, or 56 entities, including all states and territories. And this program has evolved a great deal since 2009. Originally, we were focused on the nationwide health information network, and the development of state-level health information organizations, or regional HEOs or RIOs. And that process has taken off in many states, Delaware, Vermont, in regions, Western New York, for example. But the recognition after a few years into the HIE program was that state-led organizations may not work in every state. And so the recent shift of strategy with health information exchange is to view HIE as a verb rather than a noun. So now we're focused on the electronic sharing of clinical data rather than developing state-level organizations. And so there's a lot of work around directed exchange using a common set of standards, around query-based exchange, so we can have vendors or private networks use common standards to facilitate the exchange without having an entity that is either state level or larger to direct the nature of that sharing. Finally, the last large program is the Beacon Community Program. So there was a recognition that that health IT investment is relatively new to healthcare. Anecdotally, very few physicians had advanced EHRs. Hospitals had administrative transaction systems and billing, but they too were relatively slow to particularly adopt advanced functions like physician documentation. And so since we were expecting a lot of transformation in such a short period of time, there was a recognition that we needed some demonstration programs and a way to learn from the experience of communities that had been more advanced and that have taken steps for several years to implement EHRs. And so 17 communities around the country were funded, total program around $220 million, really to demonstrate how they were able to use health IT to improve outcomes, lower cost, et cetera, or to test innovative approaches. So there are different beacons having different approaches. Some are expanding their health information exchange capability to extend it to different populations. Others are developing new innovative applications, some on the mobile health front to test whether health IT extended to consumers will make a difference in terms of outcomes. So that wraps up part one. So I wanted to give you some context of HITECH and sort of what HITECH programs are, what the motivation was. Now I'm going to turn to the data. So I want to share with you some of ONC's original survey data on EHR adoption and also meaningful use. So before I dive into numbers, EHRs are actually a very complicated subject. It's not just simply a piece of software. It's actually a system that involves many functionalities. This was recognized early on that EHRs were not merely billing or practice management, that the clinical functionality really mattered. And so the current slide shows some of the functionalities that were identified by an expert panel led by David Blumenthal and others to define the functionalities clinically that we felt mattered the most. And so a definition of basic EHR and comprehensive EHRs was developed. The basic EHR is the definition that ONC has adopted to report out on EHR adoption in general. So the slides I'm about to show you really reflect this basic EHR definition. And as you can see, basic EHRs require not just basic information, but they require problem list, medication list, CPOE for medications, as well as lab results and imaging results. And so as we've used this definition, we like to say basic ain't so basic, particularly on the imaging results side that that connecting PACS to the EHR is not trivial in many cases, and we're sort of limited in how BASIC has been growing due to that one data element. So strikingly good news in terms of adoption since HITECH. This is adoption in the physician office from ONC surveys. We partner with the National Center for Health Statistics on the EMR supplement to the NAMSIS, the National Ambulatory Medical Care Survey. So we've been running this since 2008 to measure the national estimate of where EHR adoption is. And so I mentioned BASIC. We've actually more than doubled since 2009, going from 21% of all office-based physicians to 40% this last year. We're expecting that to continue in upward growth. I think we're projecting 50% within the next 2 years. And as you can see, the top line is the any EHR. And so roughly 3 out of 4 office-based physicians have some electronic health record system. The way we ask this question is to distinguish the EHR from billing and from practice management. And so the delta between BASIC and any is really the difference in the functionalities that may be in some of the EHRs that are being adopted. And so the BASIC EHR is a proxy for us. The ONC's real interest is in meaningful use, and I'll get to that in just a minute. So BASIC EHR has a certain set of functionalities, but again, what ONC is most interested in are the functionalities that are required to receive the incentive payments for meaningful use. And here's a smaller set of those. There are actually 15 core requirements on the physician side, as well as 10 optional menu items, of which they must select 5. But this is the level of adoption by physicians in 2011. And so recording demographics is the highest prevalence at 72%. Clinical quality measures at the bottom is only 30%. But what we've been looking at is this delta here. So the arrows report the 1-year growth in the EHR functionalities. And so probably most striking is CPOE and e-prescribing. Again, going from 65 to 80% of office-based physicians having the functionality to do CPOE for medication. E-prescribing has jumped up to 73% of all physicians. While not shown here, that's actually a doubling of the rate in just a short time period. And so while the numbers are strikingly high for the top set, they're actually relatively low for the bottom set. So clinical decision support rule, 50%. Clinical quality measures still only 43%. So we recognize that a lot of work is still in place to get these functionalities up. And so one of the reasons why the lower set are low is because they're menu items. And so the meaningful use strategy is to move in stage 1, move the menu items into the stage 2 core. And so there's a movement in how the functionalities will be required across the meaningful use stages. Stage 3 will require even more advanced care processes to be automated. So while I can't share with you any definitive stage 3 requirements, there is discussion of more patient-oriented applications like secure messaging. There are population health management requirements, registries, et cetera. Stronger on the public health reporting side. So while public health reporting of syndromic surveillance and immunization is a menu item, we expect those perhaps to move into the core by stage 3. So the hospital side has also shown pretty dramatic growth over the last few years. Hospital adoption of BASIC EHRs with physician notes has tripled since HITECH, going from about 12% to just under 44.5%, 44.4% of all acute care hospitals in the U.S. have a BASIC EHR. But we're also studying very carefully the functionalities associated with meaningful use. So this is This is the full range of stage 1 requirements for 2011. And again, highlighting the change, pretty dramatic change in 1 year. And that's why I like to show this is we like to believe that high-tech and meaningful use incentives are actually changing the technology patterns. We know it may not be the only reason, but clearly the data are suggesting pretty rapid change. Probably most striking here is CPOE in the far right. CPOE for medication orders has expanded dramatically. It's around 72% of all hospitals now have CPOE for medication orders. And 16 of these 24 objectives are at 80% or higher. So 80% of all hospitals have these meaningful use capabilities already in place. And so the way this is asked is, do you have this function fully implemented in at least one unit in your hospital? And so we feel pretty good that these represent actual use of the MU functionality rather than in installation. So moving to meaningful use, which is the heart of the HITECH program, is to incentivize that providers adopt and meaningful use certified EHR technology. Around 522,000 eligible professionals, so mostly physicians. Some mid-level practitioners are eligible if you practice in certain settings. Early goals were modest. Even our 2013 goal is relatively modest, of roughly 220,000 eligible providers being paid for meaningful use by 2013. We've actually blown right by that in as of March 2013. About 256,000 eligible professionals have been paid for meaningful use. And by paid, I want a distinction. There are two different programs. There's the Medicare program and the Medicaid program. The Medicare program requires you to attest immediately to being able to meet the meaningful use criteria and the functionality that I've been talking about. The Medicaid program is a smaller program, but it's available to providers who qualify. You have to have meet a certain threshold of Medicaid patient volume. But here you will receive the payment early for adopt, implement, or upgrade certified EHR technology. And so there's what the intention was to provide a safety net institutions or those serving vulnerable populations with the upfront incentive so that they could not be constrained by capital and to get them down the road towards meaningful use in a quicker fashion. And so we're considering payment as our key proxy for being on the path to meaningful use. And ultimately, 386,000 eligible professionals have registered. That's about 74% of all eligible providers in the U.S. The hospital side is actually more striking in terms of participation and payment. There are about 5,000 hospitals that are eligible for either the Medicaid or the Medicare program. About 4,300 have registered, which is about 86%, and about 3,900 hospitals have been paid for either attestation or the AIU option, and that represents about 77% of all short-term acute care hospitals. Eligibility is subsection D hospitals, including children's hospitals and cancer hospitals. So we've excluded long-term care, acute, psychiatric facilities, rehabilitation facilities, not by design, really by the realities of the budget. And so while those facilities are not recognized here, we do emphasize health IT adoption in those facilities, and there's a lot of work going on to encourage and support adoption in those other hospital settings. So I call this my money slide. This is the amount of payments in total that have gone out since CMS EHR incentive program began making payments. So this is in millions. The red line is the total amount. $13.7 billion have gone out in incentive payments to both professionals and hospitals. You can see there is variation by month, and that reflects the cycling of the deadlines. And so we recognize that, and as students and faculty, we know nothing like a deadline to get assignments in, and so nothing like meaningful use deadlines to motivate attestation and participation, et cetera. So that's part two. Part three is want to spend a little bit more time talking about progress and what we learned. And so want to share with you about the program evaluations, talk about the challenges. I'm actually probably talking a little too fast here. So maybe I'll spend a little more time on each slide to share with you a little bit more about what we're learning from HITECH. So evaluating HITECH, we recognize was critical to the whole investment, that other countries, the UK, Australia, some of the Nordic countries, had major investments at the national level in health IT with mixed success. And one of the frustrations in the UK was what we learned about the investment in e-health, or what they learned, and what could we do differently. And so when HITECH was created, with David Blumenthal at the helm, David being a physician and also health services researcher, wanted to ensure that we learned from this experience, and that HITECH and meaningful use wouldn't be the means to an end, but it would be the infrastructure to support the continued transformation and improvement of healthcare. And so $20 million in dedicated program evaluation were written into HITECH. So this shows you the questions and the specific evaluation contracts that my office manages. And so we thought about evaluation not as a traditional intervention, that health IT wasn't really something that a physician's office was administered and that we could see a change. It was really a complex intervention that required change management. It may require interaction with context. And so in designing our HITECH evaluations, we really thought a lot about what Don Berwick writes about in his JAMA article on the science of improvement, about thinking about context, mechanism, and outcome, rather than thinking about the health IT intervention and looking at the treatment effect of that particular intervention. So we've, in our evaluation design, we've thought a lot about complex interventions. We've thought a lot about context-sensitive effectiveness. So besides what Dr. Berwick's written about with quality improvement, there's an analogous literature on the patient safety side, where Paul Schickel and others have written about the challenges of evaluating patient safety interventions and how the effectiveness of a patient safety intervention is really dependent on the organization, may be dependent on training, culture change, leadership. And so we've spent a good deal of time thinking about HITECH evaluation in that context mechanism outcome framework. And so we are studying context, which is the top question. Roughly $2 billion in program dollars were administered. Who were the grantees? What were the environments that HITECH began in? What was the mechanism? So implementation. What were the strategies and activities that each of the individual organizations took? For example, a regional extension center had a lot of choices in terms of They're contracting with local organizations to create an organization, and how they wanted to deliver their services. And so part of the evaluation process will be to study the mechanism by which high-tech and health IT ultimately achieves its goals. And so importantly to note the last line, which is impact. It's critical that we learn about the impact of health IT on the three-part aim. So the beacon evaluation, which I mentioned was the demonstration, is a key place where that will be studied, as will the global assessment of high-tech, which is a sort of a meta evaluation effort led by Mathematica, Policy Research, and Urban to look broadly at the interconnectedness amongst the high-tech programs and ultimately to measure what the impact of high-tech and meaningful use was on costs. So a little bit more on the logic and the emphasis on telling the high-tech story. So the four pillars flow from the questions, context, implementation, and then ultimately outcomes. At the bottom is really my office's strategy. So these are four-year evaluations of a four-year program. So we didn't view a program evaluation in a traditional sense of we'll give money to a third-party evaluator and then have them come back 4 years later with a summative report. We're really viewing ourselves as a partner in this evaluation process. So ONC has a dedicated office that has an evaluation staff that is both working with our contractors as well as doing some of our own internal analysis and research. So we hope to provide more timely feedback. And so we have a number of reports and briefs that are in the public space already. A plug for our Health IT dashboard site at dashboard.healthit.gov is my office's public dissemination vehicle for both data and evaluation findings. There's a tab there called Evaluations that has a full access to all of the briefs and reports on the formative side that our evaluations have produced to date. And of course, several peer review articles have been developed, and we're driving to the summative reports, which will be coming out as early as 2015 for some of the programs that are ending now. So a little bit more dive into some of the specific programs. So the Regional Extension Center program, again, is probably the largest in scale. 62 centers. This is a screenshot from our dashboard site. Over 140,000 providers participating against the goal of 100,000 that we had hoped to work with. So we've exceeded the numbers in terms of our initial goals in terms of participation. Over 100,000 of our REC participating providers have already gone live on an EHR. And about 60,000 have achieved meaningful use. We're working really hard to get the remaining 140,000 to meaningful use. 140,000, and remember these are priority providers, which by our definition is primary care, small practices, serving in rural areas, serving in HIPSAs and MUAs. That's about 40% of all primary care providers in the United States. RECs have made a dedicated emphasis on the little guy. So we're working with about 80% of federal qualified health centers and about 80% of critical access hospitals and small rural hospitals. So there's a real emphasis on making sure that any digital divide that may have existed in health IT is not exacerbated and hopefully will ultimately be closed. So on the REC side, probably the biggest challenge that we've learned from the program is on the organization side. That when you give dozens of millions of dollars to a local community organization, how do you put together the team that can provide technical assistance? And so many RECs are more or less a virtual organization of a lead entity with subcontracts to other community partners to provide different services, for example, vendor selection or practice redesign. And so one of the big challenges is just in coordination and in governance of how the technical services are provided. So what is one of the main lessons from the REC program is on the importance of champions, so local champions. ONC recognizes early that a change agent is often essential, particularly in professions. And so having a physician in a particular medical society be visible and to take the lead in championing the benefits of EHR as well as the how to use EHR to achieve meaningful use was critically important. On the workforce side, this particular slide shows the community college attainment. So the goal here was 10,500 community college students trained. We've blown past that. Over 22,000 students have enrolled. 17,000 have completed as of earlier this year. On the UBT side, we're very close to achieving our goals there in terms of the total students completing the program. So the big challenge with workforce training is the diversity of the student population. That many of these programs are online, so probably very surprising in terms of data. The average age is 44, and many of these students currently have jobs, and so one of the early hopes was that we could help students that didn't have a job get jobs, and so we've seen modest success there. But probably the biggest lesson from the program is what we're ultimately doing with the workforce training programs is helping nurses and med techs and medical record staff workers move from their current position into a health IT support role. And so there's a lot of shifting in roles within organizations, and we believe the workforce program has enabled the labor force to make those changes. Probably the biggest challenge for us has been on the vendor side, that it's a chicken and egg. Students want to help implement, and so they want to get experience, yet vendors in particular and some delivery systems require experience. And they actually require experience with a particular vendor. And so probably our biggest challenge is getting students access to the proprietary software and getting them experience through internships, practicums, even through online module training before they actually go out on the job market. And so we're sort of having this challenge now of more informal opportunities for students before they land permanent employment. So the Health Information Exchange program is, as I mentioned earlier, is probably our most complex program, and certainly the program that's evolved the most since the genesis of HITECH. This shows states' success in getting hospitals to participate in the various exchange models that they're offering. So some states like Delaware and Vermont have been very successful in getting their hospitals to participate in directed exchange. There are a couple of standards-based mechanisms that ONC has been promoting. Direct is one of those, which was basically to solve the secure transmission problem. So direct is a standard that will enable various messages of various forms to be securely transmitted across entities. States like Delaware have a state-led health information organization. So it's and that RIO had the hospitals participating in it, so it was relatively easy to get them to participate with direct. Other states, Utah, Tennessee on the right with Query, don't have state-level HEOs. They have regional organizations. So around in Vanderbilt area, there's an operational HIE, but really extending the entity model to the rest of the state has been our challenge. And so Part of dealing with the challenge of the politics and the technical challenges has been the emphasis of the HIE program was really to facilitate HIE as a verb or exchange as activity rather than HIE as a noun, which is the entity governing health exchange, health information exchange at the state level. And so, as I mentioned earlier, some states like Delaware and Vermont have very robust state-level HIEs. Other states like California are likely never to have a state-dominated exchange. In California, there are regional efforts going on in California, but it's uncertain whether a state-level network that is the de facto platform for exchange in a state will ever exist. And so, given that reality, the HIE program has been emphasizing mechanisms to facilitate sharing. And probably one of the biggest lessons actually from the HIE program is to partner with the states. So ONC is the federal entity that's coordinating health IT adoption exchange, but we're the catalyst that states, particularly through their policy arm, can be very effective. And in particular, legislation and additional investment through financial incentives or through requirements that providers in their state must use EHRs. They must share the record through interoperable standards. States like Minnesota and Massachusetts have passed legislation to require providers to adopt EHRs, and so we've seen pretty dramatic increases in both EHR penetration as well as health information exchange in those states. Beacon communities, these are the community-level demonstration projects. So some data from a couple of the beacons, Greater Cincinnati focused on asthma, the Keystone Beacon, which is in Pennsylvania, focused on readmission for congestive heart failure patients. We are seeing improvements, and that was the intent of the Beacon program, was to challenge 17 communities to move the needle on outcomes. And where we are with Beacon is trying to understand now how they did it. So the data suggests that it can be done. Now we really want to understand the processes, the organization. How were these community organizations able to improve care? And so one of the challenges, though, is engagement. These are diverse communities, Greater Cincinnati, competing hospitals, Pennsylvania, also hospital competition, more rural in Pennsylvania. So engaging providers that are not centrally located within the facility is a challenge. And probably the key takeaway from Beacon is that health IT alone is not sufficient to improve outcomes. That it really is. It requires behavioral change. It requires system redesign. It may require new applications in the case of patient engagement. And so the evaluation team is trying to document these lessons, but we're hoping this is part of an ongoing process of learning from health IT implementation. Thank you. So that's a little bit on the official HITECH programs. Wanted to share with you some data on our certification program. One of the economic rationales for HITECH was that the market was not functioning properly, that it was dominated by a few proprietary vendors. There was a lot of uncertainty in terms of price and quality, and that as an economist, what you want to see is free entry and competition on price, and some assurance that quality would meet a certain threshold. And so we required providers to have a certified EHR to meet meaningful use. Since the launch of the certification program, about 3 About 1,800 unique products from over 900 different vendors are now available for physicians and hospitals to select their choice to achieve meaningful use. And this is a slide as an economist I'm most proud of, which is the competitiveness of the market. So on the left shows you the Herfindahl Index, which is a measure of market concentration. For the far left is physicians. The next to it is hospitals. A lower number means more competitive. Relative to the right is telecom and the tablet market. So our numbers suggest that the EHR market is highly competitive, even though it is in terms of absolute market share going to a small number of vendors. Around 10, 15 vendors have the lion's share of the business, but there are a large number of competitors, which actually makes the market competitive itself. So lessons, I mentioned these before. Moving ahead to the challenges, 3 key challenges. Benefits is the biggest challenge for us. Media have presented results suggesting that EHRs increase costs. Some members in Congress are questioning now the value of health IT. I've got a couple slides showing some of original new data on the benefits. So this is from our physician workflow survey, soon to come out in a data brief, that most physicians report that EHRs do improve practice. About 80% believe it provides clinical benefits, and the darker blues are the numbers for among physicians who use a certified EHR, and then also the darkest blue is after 2 years of experience. So the take home here is there are benefits from EHR, and they get better with an MU system, and they get even better after 2 years of experience. We commissioned RAND, who has done several of the systematic reviews in the past, to update their systematic review of the literature. This is about to come out in a report and also a peer review article. Around 76% of the recent literature reports positive or mixed positive findings overall. The evidence of HIT value is strongest in safety, mostly from studies of CPOE and CDS. Weakest in efficiency. So we recognize this, that the economic evidence on health IT reducing costs and improving efficiency is relatively sparse. And so my office and we're hoping to encourage academics to start investigating this, that clearly health IT is changing behavior, and we believe that it will reduce complications, that will ultimately make things more efficient, and we need to measure that and show how production is shifting to a different process that's enabled by health IT rather than simply trying to measure the old paradigm. So the second biggest challenge is interoperability and exchange. It's the toughest nut to crack. Clearly, proprietary standards are out there. Vendors are entrenched in trying to lock customers into their system. We've been challenging them. So in meaningful use requirements, there's a requirement to interoperate across vendor platforms. We also know that just the capability to exchange is not important. We want the information to start flowing. So there are requirements for transmission of lab test results from hospitals back to ordering physicians. There are requirements for public health reporting, as well as patient exchange. So there's new requirements for patients to have access to the electronic health record with the ability to view, download, or transmit parts of their record into a PHR or through a portal or however that might occur. And there are policy initiatives to complement HITECH in focusing on providers. There's a lot of effort in ONC and in HHS on consumer e-health and engaging patients as a partner in this process. There's a Blue Button initiative launched by the VA so that patients can, in a simple push of a button, to download Medicare claims information into an app. It can be an iPhone app, it can be PHR, And we've been working hard with patient advocacy groups as well as insurers to make sure that the role of the patient in incentivizing health IT use is not overlooked. A few challenges I haven't mentioned: usability and safety is paramount. A lot of new errors and unintended consequences to poorly designed interfaces and changes in workflow that have not been implemented properly. Maybe it's training, maybe it's culture. Likely can be improved through re-engineering. Certainly, software can be better, integration can be better. A lot of new work around studying that. So how can we ensure that EHRs do not harm patients in a way that was unintended? So that's all I have for the formal. Happy to take some questions.
We have a live mic here in the room, and again, anybody that wants to communicate via Twitter.
On the slide where you had, can you hear me? Okay. On the slide where you had the weakness of the efficiency, how much do you think that really is contributed just to change, the old learning curve?
It's a good question. So efficiency may be weaker because of the learning curve. Productivity may actually go down with the EHR implementation, and physicians, nurses, others may be reluctant to use the technology in a way that will actually improve efficiency. So in many cases, we don't measure time savings. And in many cases, we don't see staffing levels go down. In fact, they may increase because while nurses are in training, they need to hire consultants and others to offset that. So it's a ripe area for research. I think one of the questions on efficiency is whether care delivery will fundamentally change in a way that efficiency will improve because roles are changed. So nurses may be able to automate certain low-skilled functions, and so there may be less need for assistance, and whether mid-levels can take on certain roles in practice where we may see time efficiencies in certain cases. And ultimately, we do believe that the hard dollar savings will be there, but we are in a learning curve overall, I think, for the system.
On one of your slides, you showed very high penetration of docs using Office. On one of your slides, you showed a very high penetration of Office docs success with, quote, computerized provider entry for medication orders. Now, my understanding of office practice, I'm an ER doc, but office practitioners are typically not ordering medications in the office. They're prescribing, things like that. So I wonder what you're actually measuring there that gives you that kind of information.
Sure. Well, this is a representative survey, and it includes physicians that are practicing in the outpatient hospital setting, and also physicians that are on the medical staff where they may have access to the hospital system. So admittedly, CPOE traditionally is an acute care application. I think the way that respondents are seeing it partially is that they may be actually having a common hospital and ambulatory system. So, for example, hospitals that have extended their EHR into the practice setting, they would see that as an extension of CPOE. I think it's also confounding e-prescribing with CPOE for medications. And so e-prescribing is high. It's not exactly the same as the CPOE for medication orders, but I do think there's some overlap there in how the respondent is viewing electronic prescribing, which would be the ambulatory term, versus CPOE, which would be more the acute term.
Thanks. That was a terrific review of the program, and really appreciate the effort you're putting into the evaluation side. That's something that's very much been needed, and there's been a lot of requests for feedbacking and feedback into the new stage requirements. So it's terrific that you're doing that. I question your analysis. I'd love to hear you elaborate more on why you think it's great to have as many products as we have, because my intuition on that has been that given the scale of requirements that we have for these systems, that it's very hard to have that many vendors able to keep pace, and that's my observation, is that an awful lot of them just can't produce the usability research and meet the requirements. So maybe we have too many vendors. What do you have the right measurement of that?
That's a great question. And so that was part of the philosophical debate of the role of government at the beginning, and it's a continued debate in HHS and ONC about the hand of government versus letting the market incentivize innovation. And so there are a large number of vendors. I guess I'll say my personal view is I don't believe all these vendors will continue in the marketplace. That as an economist, we know there's competition, there's disruptive innovation, there's a churning of the market, there's entry, exit, consolidation. And so personally, I do expect that. I think putting my own hat on it, we also do expect that. And so, but what we're fostering is to allow competition to incentivize innovation. So we have a set of criteria that are in regulation, and we have a certification program to ensure that all vendors meet the requirements. So in terms of minimum quality threshold, we're pretty confident there. On the usability side, we're working on that. There's a lot of awareness that the user interface could be designed better, that there's not harmonization in terms of standards for the interface. So we're again taking a decentralized or open approach in terms of not regulating what we think usability should be, but allowing competition and information to shake that out. And so there's interest in collecting perceptions of usability to formally measure usability. I think a lot of interesting research will be done in that area. And ultimately, the more we can get a consumer report style assessment from actual users, and even to correlate that with actual outcomes, to say that these are the user interfaces that in human factors design and physician experience are optimal, that they actually do result in better outcomes and efficiency. And once we get that transparency in the market, I think we will see a shaking out. That some vendors will embrace that, and they will compete for that the set of products that consumers and providers want. The informed ones will want. That being said, Consumer Reports is available. Not everyone uses Consumer Reports, and so there will be probably a different market. There'll be and people are locked in too. So it's also a challenge we have in terms of you've made the investment, in some cases millions of dollars on the hospital side. You can't scrap it, and so how do we ensure that the large number, the long tail of small numbers of clients with a lot of different vendors that they can transition to meaningful use and to some of the usability issues that we think the market's eventually going to go. And so we'll do everything we can to facilitate that change.
One last quick question, quick response, if you have the mic.
Thank you very much for the wonderful lecture. I wanted to kind of follow up on your comment of the hand of government versus let the market innovate. So the example here is health information exchanges. Currently, most of them are surviving on the ONC grants, and they are basically not yet self-sufficient economically. On the other hand, we have large EHR vendors like Epic or the recent alliance of Meditech and Cerner creating these very large multi-state data repositories for all their patients. Where would you see, again, based on your comment, the hand of government versus let the market innovate, would it be a better use of resources to actually incentivize these EHR vendors to expand and interconnect their data repositories versus create a whole HI, RIO, and NHIN network?
That's a great question. And Farzad Mostashari, our national coordinator, has addressed this in several of his recent public speeches, that we want information to flow. And as Farzad emphasizes, ONC and HHS will use every lever at our disposal to enable that. And so in terms of the vendor-to-vendor interoperability, we recognize that. We recognize there needed to be incentives. And so it was built into Meaningful Use Stage 2 that providers at least show that they have the capability. And so we do recognize the vendor community will need to be partners with the ONC and with providers in enabling this. But certainly the goal is to have information flow and to have access to EHR data. And we have not seen the hand of government be necessary to specify how that would occur. And so our strategy is to allow local markets to determine what will work for them and to support that. And in cases where there's an operational HEO that has a business model for sustainability, we do support that. Where there are private networks, some being built for ACO connectivity, we are supporting that. In terms of encouraging vendors to embrace standards to allow interconnectivity, a large new emphasis is being placed there. And so, again, HIE as a verb, and to create incentives for the sharing of EHR data. And so, recent policy effort was the partnership with CMS to issue a request for information back to the delivery system, including vendors, and how we might do this. The goal is to share clinical data to improve outcomes. One option is to use Medicare payment policy to require interoperability. So the meaningful use incentives are a down payment on what we hope will be a longer-term pay for performance through some of the quality programs, maybe through some of the new ACA-related models that are coming down the pike. So it's an evolving space, interoperability is. And one of the things we're committed to is listening, and we're also committed to learning. And so we don't have the silver bullet for interoperability. But we, as far as I said, we will relentlessly pursue this with all levers at our disposal.
So again, a great talk. Thank you, Mike. And those of you watching us on archive, if you have any questions, you can, Dr. Furukawa had his email up there last, or you can contact myself, Jonathan Weiner, or Harold Lehman. And thank you all for participating either live here in Baltimore, or live online, or by archive in a fantastic talk. We look forward to seeing you punch through the rest of your targets. A great job, and thanks for working on our behalf.
I was wondering if I could get a copy of your slides.
Yeah, I think so.
I have if this works. I mean,
Email me. Let me make sure that's okay. Because I'd rather contact me via email.